Thank you very much, all of you, for being here. I see colleagues from all kinds of Indonesian institutions. That makes me very proud and happy. I'd like to introduce the project a bit, and Yusi and Katarina will also help to explain what it is that we're going to do. I'd like to thank the UK government and the Department of Health through the National Institutes of Health Research and the 33 million British taxpayers, of course, who are making this all possible. We're very aware that this is public money, and we intend to try and spend it as best we can to answer a very important question. Now, this question goes back, if I can, to a report that was launched in November of 2017. Dr. Penny Lukito, who many of you will know as head of the Indonesian national regulator, BPOM, joined Dr. Tedros, the head of the WHO, to launch this report. And it drew attention to the importance of substandard and falsified medicines. And you've heard something about this from many of the previous speakers in the video. So medicines that don't meet quality standards or that are fake don't treat patients. They can sometimes even kill them. They allow resistant bugs to spread, so they contribute to antimicrobial resistance. They waste money for families and for budgets, and that's particularly important in countries like the UK, which has a National Health Service, and Indonesia, which has JKN, where a lot of medicine is funded by public budgets. So we really need to make sure that medicines are not wasting money. So these things are all very, very important. And yet, when you come to saying how big is the problem, well, this is what the WHO says. You know, the question's frustratingly difficult to answer. And then in the same report, well, how big is the impact of these things? Studies are virtually non-existent. Now, for those of you who do not speak fluent WHO, what this means is we have no idea. We really don't know how bad this problem is. Now, I can say that with some confidence because I was involved in writing these reports, and we really looked very, very carefully at all of the data internationally, and we found that no single country has actually got an estimate of the prevalence, the amount of substandard and falsified medicines in its market, let alone the impact. So why is that? Well, it's partly because of the needle in the haystack problem. Where do you begin to look for these things? In the Indonesian market alone, there are over 13,000 individual products registered. If we look at public procurement, 2 years ago, the public procurement system bought 7.6 billion units of medicine. So some of those are going to be good, most of those are going to be good, a very small proportion will be bad. So where do we start to look for them? Now, as Professor Weber mentioned, I have a background, a history as an epidemiologist in HIV. And this made me think about HIV. And you're going to think, huh? Why is she talking about HIV now? We're talking about medicine quality. But actually, they're quite similar. Why? Because they're important threats to health. They're virtually invisible. They're quite rare in the population in most countries, or in the markets in most countries, but they are not evenly distributed through a population. So I had the privilege a very long time ago, nearly 20 years ago, of working with the Indonesian Ministry of Health, with Kemkes P2M and the Statistics Bureau, BPS, to try and strengthen the national surveillance system for HIV in Indonesia. And at the time, most of the surveillance was in pregnant women and in blood donors, which is a bit like taking a random sample of the population. And what that found was nothing, basically, because this is so rare, and most pregnant women are not at risk for HIV, because at that time, HIV was concentrated in well-known groups, and that is injection drug users, sex workers, gay men. So when we started to focus the surveillance system on those risk groups, you found that you had a much higher yield, a much higher level of positive tests, and we got a much better understanding of the epidemic. So we began to think, maybe you could use this same principle of risk-based surveillance for medicines. And we went to our colleagues at BEPOM and said, what do you think of this idea? And ternyata, of course, BEPOM, who are the experts in this, are way ahead of us. And they've been doing risk-based surveillance for quite a number of years now. And then we started talking with them about, okay, well, what are the groupings, the factors that actually are included in risk-based surveillance? And in the multi-country study that Prof. Roland mentioned, we found one very, very important factor that was not currently included in the risk-based surveillance. And those are market factors. So they're factors that relate to pricing, to the incentives to produce or to sell products in a given market. And the expert in pricing in our team is Ibu Yusi. So I'm going to turn over to Ibu Yusi now.
Thank you, Ibu Elizabeth. So as we know, since 2014, the Indonesian government has implemented universal health coverage, and there were significant reforms in the health sectors, including medicine procurement and a pricing policy. Procurement and pricing policy in Indonesia changed through the implementation of national formulary and e-catalog that to be used in the e-purchasing for the healthcare under the universal health coverage. The medicine price in Indonesia is set through negotiation or tender process, and it has an impact on medicine price. Our study showed that medicine price in Indonesia tended to fall steeply. From this figure, we know overall 42% of all medicine fell in price by 50% or more. In other words, their price was better compared to before the implementation of universal health coverage. And we also observed there are increased price in medicines. Over a third of those that rose in price rose by less than 25%. And based on this evidence, we all know that the government has made a priority of bringing down medicines prices through the public procurement system. This slide is our current analysis of the current prices for a number of essential medicines sold in a catalog with the cheapest price in the market in Thailand, another Middle Asian country that aims to achieve universal health coverage too. From these figures, overall Indonesia gets better prices, which should be a source of pride for the government as achievement of the pricing policy implementations. But sometimes we have to think the prices perhaps a bit too good, or sometimes we can see it is too low. That raises question about how the Indonesian producer can produce quality products so cheaply. If we observe another sites, we also have a few of medicines price very high. It is more than 3 times than Thai price. So it might be attractive to target for the falsified. So we have some cases of the falsified medicine or also substandard medicines, and will be described by Ibu Elizabeth again.
Thank you, Yusi. I think that the issue of falsification is particularly interesting right now with the rollout of the COVID vaccine. And I think that we're seeing cases of falsified vaccines even in the US with, you know, the FDA is supposed to be one of the strongest regulators, but in the online supply chain, they can't control that. We're seeing substandard production. In the neighboring Philippines, we've also got verified cases of falsified vaccines being injected. And in India, partly because of the effects of COVID, we've seen a rise in substandard production of many medicines. So these highlight some of the groupings that we now think could be used for sentinel surveillance for medicine. So in the same way that we had those behavioral groupings for HIV, we're thinking that we can use these sentinel groupings for risk-based surveillance for medicines. Now, some of these are already being used by BEPOM and some of them are additional. So for an example that we just saw from those press cuttings, internet purchases, particularly of things where there's a very, very high demand at the current time, either for medical reasons like COVID or for recreational reasons, for example, because something is used by addicts. So the reason that we want to try and increase, so on the basis of this surveillance, we'll then make very simple spreadsheet-based estimates of the overall prevalence of medicines in the market. The reason to do that is not because we just want to know, but also because we want to know the impact on people's health and on the economy and to inform policy. And I'll let Katerina tell you a bit more about those impact estimates.
Yes, thank you, Elizabeth. So really what fascinated me about this project is that we are faced with a problem that is truly unknown. Often we test a hypothesis in academic research, but with this, we really have no idea whether these indeed frightening numbers and figures that you see on the slide, whether these are true, whether the numbers actually, the real numbers are higher or the real numbers are lower. We don't know. So there's very little evidence, which makes this very exciting for me, this project. Now, also from an economic point of view, we know that the cost of post-market surveillance of medicines is very high. This begs the question, how much should countries actually invest into such regulatory systems? And in order to do that, we would need to do a cost effectiveness analysis of surveillance and regulation. And for that, we need solid estimates of the impact of falsified and substandard medicines. And we can distinguish really health impacts and economic impacts. And these are the ones that we will be attempting to estimate with this exciting project. Now, first, of course, we have the direct health impacts on patients due to increased morbidity and unfortunately mortality arising from adverse events, wrong dosage, wrong medication altogether taken. If the medication was meant to treat an infectious disease, we have the additional problem that it might increase transmission dynamics and that it will lead to secondary infections. So we will use the expertise that we can fall back on in the School of Public Health in infectious disease modeling to attempt and estimate these impacts for one specific disease, which is yet to be determined. We also have a problem, of course, of poor adherence and vaccine hesitancy if patients realize that the medication is not doing what it is supposed to do, and the problem of antimicrobial resistance that Elizabeth already mentioned. Now, this has the problem that health systems are burdened with patients who need additional treatment, prolonged treatment, potentially for conditions that have worsened. We have adverse impacts on work productivity of individuals who are not treated properly for the conditions that they have, with the adverse economic impacts on households. And then, which I think is a really very interesting aspect, is the pharmacoeconomic impacts. Elizabeth, if you please advance the slide. So really, there is uncertainty about the quality of medicines, clearly. It's very difficult for a purchaser of a medicine to determine what the quality of that product is. And we know if there's high uncertainty about the quality of a product, such as a used car, the same applies to medicines. We have the issue that there are adverse incentives for the producers of good and bad medicines, and it may lead to a downward spiral in quality and in prices. So what Jussi mentioned before about there being a downward pressure on prices might well be also that this market of lemons, like how economists call that, this downward spiral in quality occurs. And we certainly have the ambition to understand more about these pharmacoeconomic effects. Thank you.
Yes. Would you please to press down, Ibu Alice? So discussing about medicines, there are several responsible stakeholders related to the medicines in Indonesia. There are Badan POM, we call here Drug Regulatory Agency, responsible for pre-market registration and pre-post market quality assurance. This is the main institution who are assure the quality of medicine in the market. The second one is Ministry of Health, responsible for setting a maximum selling price at selection medicine for the national formulary. And there are also National Procurement Agency or AKPP, responsible to manage procurement for the healthcare facilities under National Health Insurance. And then we have BPJS Kesehatan. It's very well known now because it is a national insurance agency, BPJS, bigger payers in the world now as a payer for the health system. However, beside the core stakeholder, our institution also have a significant role that might influence the quality of medicines. Therefore, we hope through this 3 years research project, we could collaborate to those stakeholders and provide the evidence related to the prevalence, estimations, and economic impact on medicines quality. We do hope to build a strong collaboration between institutions on Pokja Estimasi Mutu Obat. We call it PEMO. And in English, it is Working Group on Medicine Quality. And I'm very happy today. Most of the institution in this logo we are inviting and then they coming in this event. There's Badan POM, Kemkes, also other institutions. That is very positive for us, and then I am very happy to work with all of you in the future. And on behalf of our team, I would like to say thank you very much for coming. And we are looking forward to working with all of you in this area. And this is our team, and we have also Prof. Wahono as the senior advisor on the pharmaceutical policy, and Ibu Luki as STARmeds as the former of the National Regulatory Agency as senior advisor for us in Indonesia. And others, we have a very strong team, and I happy they are very support to conduct this event today. Thank you so much, and I will give the time to the MC. Thank you.